So I want to welcome you all again. My name is Druthi Chen. I'm a clinician scientist at the University of North Carolina. I'm honored to moderate this session today on the behalf of the Kidney Health Initiative. KHI, or Kidney Health Initiative, is established as a public and private partnership to catalyze innovation and development of safe and effective patient-centered therapies for people with kidney disease. The partnership includes many members, patient advocates, the American Society of Nephrology, and the FDA as well. One of the goals, which was identified several years ago, was to focus on APOL1 kidney disease. And to achieve this, the KHI formed a work group with several subgroups to create a roadmap. The goal of the roadmap was to evaluate the current landscape of APOL1 kidney disease, and envision the ultimate goal for patients and providers in the context of APOL1. Next slide. The published document, which we call the roadmap, was the result of this work group's effort. It includes some short-term and long-term action items, which organizations or groups or patients and community members can refer to. Today's webinar is going to focus on goal 2, which was to facilitate a deeper understanding of the importance of genetic testing for APOL1 kidney disease and the associated counseling. So I will first introduce the roadmap briefly, then we'll have some additional presentation by Sharon Rouse, who's a patient advocate, and Ms. Mary Beth Roberts, who's a genetic counselor with a special interest in kidney diseases. Interspersed, we'll have some poll activities to gauge audience interest, perspectives, and then we'll be monitoring comments, as I mentioned, for discussion, which will happen at the end of the session. So welcome again. Next slide. So KHI unveiled this educational roadmap aimed to address APOL1 kidney disease with the goal of reducing health disparities in chronic kidney disease. KHI created it really to highlight the significance of APOL1 within kidney care and shed light on sort of the lesser known kidney condition. This roadmap leverages socio-ecological model to emphasize the interconnectedness of various systems influencing health outcomes. And I'll sort of talk a little bit more about what this means. The roadmap is a collaborative effort, involved experts in nephrology, in clinical studies, patient advocates, health equity groups, genetic counselors, and clinical product developers. It acknowledges that the existing efforts by patient groups, advocacy groups, and pharmaceutical companies and other organizations are important to address APOL1 kidney disease and the health disparities that exist in CKD. And so from this collaboration, the roadmap was created to serve as a resource for individuals and groups such as healthcare providers or patients and families, community groups of those at risk, patient advocacy groups, and also policymakers. Next slide. So as a brief overview, I'll talk a little bit about APOL1 kidney disease. This was really covered in our first webinar by Abdul Patel, which is available, and we'll put a link at the end as well. APOL1 kidney disease is a genetic condition. It affects people who carry high-risk APOL1 variants. And most people with those variants are of African ancestry. So we all carry APOL1 gene. But if there's a variant or a different gene, there's 2 copies of that, that's what we consider high-risk APOL1 gene variants. African Americans represent 13% of the US population, but they account for approximately 32% of the patients receiving dialysis. And a substantial number of these patients have a high-risk APOL1 variants. Up to 50% of African Americans with non-diabetic chronic kidney disease have APOL1 variants in some studies. And we think APOL1 high-risk variants may account for much of the increased burden of chronic kidney disease in patients and people of African ancestry. So this is a broad-reaching problem. Another aspect of this is that APOL1 high-risk patients may experience kidney disease onset even before the age of 50. And the nature of chronic kidney disease is such that it can be asymptomatic until it reaches advanced stages. And so many patients may not even know that they have kidney disease. Um, Currently, there are no approved targeted therapies to treat APOL1 kidney disease. However, there are ongoing clinical studies, and we really want to emphasize that there's a need for more clinical research and studies to advance treatments. That's part of a part of the goal of the roadmap as well, is to emphasize this. Next slide. So to give you an overview of the roadmap, there are three primary goals. One was to increase the awareness of APOL1 kidney disease. And as I mentioned before, the webinar prior to this one really went in depth about ways to do this and had some excellent speakers I would refer you to. The second part of the goal of the roadmap was to increase awareness and access to genetic testing and counseling. And this is where we will go in a little bit more in depth with our perspective from our patient advocate as well as from the genetic counselor. And lastly, we want to empower patients to make informed decisions regarding genetic testing or clinical study participation. And so each goal has been set up to sort of target the challenges that we've seen in the past in the current landscape. And moving forward, there are additional challenges that we have to tackle to meet these goals. Things such as health literacy, systemic mistrust of healthcare, lack of provider awareness, and then access to testing. We think these goals will achieve achieving these goals will achieve meaningful change in kidney health equity for individuals of African ancestry who are disproportionately affected by kidney disease. Today's webinar will really focus on the second goal of this roadmap. So I'll outline some of the challenges, outline some of the solutions, sort of the broad themes of the solutions, and then I'll go into some of the action items which are outlined, which are included in the roadmap. So as I mentioned, the second goal of the roadmap is to increase access to and awareness of genetic testing and counseling. We want to support access to testing for patients, enhance the awareness, and then also focus on provider training to enhance awareness of what genetic testing means so that providers will encourage patients to interest in testing. Next slide. So what are some of the challenges that we may encounter or we have encountered? First of all, APOL1 genetic testing is not currently consistently used. It can vary by provider or by site. Many healthcare professionals may not even be aware of APOL1 kidney disease, or those who are aware of the condition or the potential associated health risks and don't regularly discuss APOL1 testing with their patients. Maybe they don't have the additional resources or additional knowledge to discuss this. There are companies and academic institutions offering APOL1 testing, including some that are no cost. However, for those who don't have that option available, the cost can be a burden, especially for individuals with low income. And then from the perspective of patients or the community, people considering testing may be worried about possible discrimination based on the test results. And while the GINA, or the Genetic Information Non-Discrimination Act, protects individuals in circumstances such as hiring or health insurance, there's definitely gaps in GINA, which don't always protect people from discrimination related to genetic information in all circumstances. For example, GINA doesn't apply to other kinds of insurance like life or long-term care insurance. So these are sort of the challenges in the landscape currently of APOL1. Next slide. What are some of the themes or solutions to address the challenges that I outlined? And these are the broad themes. And I'll go into the action items related to these as well. But in terms of training, we feel that there should be a focus to embed genetic testing into routine care practices, and to promote adequate genetic counseling and follow-up after the testing. And also this develop and disseminate and provide best practices for providers. In terms of advocacy to achieve to overcome some of the challenges, there should be advocacy for APOL1 testing, which reaches policymakers, and especially a focus in closing the gaps that I mentioned in GINA. And then broadly, engagement of the community, engagement of providers and patients will help convey this concept of precision genetic medicine that we test with the ultimate goal of providing information to patients and providers, which may impact their long-term care. We want to do it in ways that are effective communication for patients and providers. And very importantly, we want to protect the data, the genetic information, the data. We have to be very mindful of how this is shared with patients, how shared across EMR, and shared broadly. And also at the same time, give providers and patients additional information on GINA to understand what the individual rights are. And overall, one of the goals or one of the solutions we think is to diversify the healthcare workforce, really to represent the patients that are being cared for as well. Next slide. So I want to highlight some of the action items related to the solutions that I just suggested for each of the sort of broader themes. One of the things in terms of provider training is that we want to develop and implement continuing medical education to promote awareness of APOL1 genetic testing. What are the options? What are the processes for healthcare providers? And this will include healthcare providers, public health officials, related organizations, medical institutions, laboratory diagnostic companies as well. And there are already patient organizations that are helping to fulfill some of these actions that we'll mention. And then the next action is really to offer healthcare providers broadly, nephrologists, primary care doctors, pharmacists, other allied health professionals training on GINA to inform patients of their rights. So this can be done alongside discussion of APOL1, alongside discussion of testing. And the testing. Currently the Human Genome Research Institute has webinars on GINA that are open to all providers, and there are many great, fantastic fact sheets available as well. In terms of support access to testing, we want to promote inclusion of APOL1 in the ACMG guidance on genes that can be evaluated in individuals who are undergoing clinical exome sequencing or genome sequencing. And then we want to enhance testing awareness. So build trusted relationship with communities of African ancestry to promote APOL1 genetic testing. Several nonprofits and initiatives are already completing this task as well. So next slide. While the audience list I sort of mentioned is not exhaustive, I do want to highlight how these different audience members can play a key role in connecting the right people and implementing or promoting our action items that I just showed you in the roadmap. Next slide. I've raised this multiple times, but healthcare providers can really play a crucial role in raising awareness about APOL1 kidney disease and facilitating access to genetic testing. Patient advocacy groups are instrumental in educating at-risk populations, empowering patients to make informed decisions about their health. And then policymakers can support initiatives to improve access to healthcare services and promote health equity in chronic kidney disease care. And then last but not least, the community organizations, particularly if those at risk for APOL1 kidney disease, can provide important resources to patients who are looking to gain knowledge on the condition and to sort of foster interpersonal connection among patient groups as well. Next slide. All of the things I've highlighted so far really stems from KHI's mission. The Kidney Health Initiative is committed to driving positive change in kidney health equity, really through collaborative efforts, and which is what I've tried to highlight in the roadmap description that I've showed you so far. We hope that long term, the APOL1 kidney disease roadmap will empower those at risk to make informed decisions about participating in clinical studies so that with the goal to improve overall health outcomes. Ultimately, creating APOL1 kidney disease therapies is important and making them available to patients of African ancestry. We want to empower the patients who are at risk to make informed decisions, to understand their genetic testing and how it can impact their treatment moving forward. So that's my summary of the roadmap. Next slide, please. With that, I'm really pleased to introduce Sharon Rouse, who's only a kidney disease and transplant survivor, but she is also passionate and dedicated patient advocate. Sharon founded Kindness for Kidneys International, which is a nonprofit dedicated to educating, encouraging, and empowering kidney warriors and their families. We're so happy to have her here to share some of her insights with us. Thank you, Sharon.
Thank you so much, Dr. Chen. What a very informative presentation. I'm still learning, so I was learning as you were presenting. And so I'm delighted to be here, and I want to thank the Kidney Health Initiative for this opportunity to share my story. Whenever I show up to share my story, I know that I'm not speaking just for myself, and I count it an honor and a privilege to speak on behalf of kidney warriors around the world. Next slide, please. So just a little bit of background. I was born and raised in Maryland, relatively normal childhood. I'm the oldest of 4 children. I'm a wife, a mother, and I used to be an educator. I taught in the classroom, was a resource teacher. And then in 2021, I decided to resign and focus my efforts more on my entrepreneurial adventures and journey. And you'll hear a little bit more about that. And so my goal in life was always to help others. I can remember even as a child, I've always been one to want to jump in and help, or most of the time from the background because I didn't like the spotlight. But I wanted to just jump in and help as the oldest child, and always wanted to help my siblings, always lending a helping hand to anyone that needed it in my family and my friends. And so I feel like that's been a common theme throughout my life. It's just I love helping other people. I love seeing other people win. Next slide. And so my journey with kidney disease began on September 22nd, 2006, from what I know. So I'm sure that my journey began long before that. But as Dr. Chen mentioned, many times you don't know it until it's in an advanced stage and at the end when it's time to do something and to take action. And so I found myself in the emergency room on September 22nd of 2006. It started out as a normal day. I gotten up to go to work. I was a school counselor at the time, and it started out normal, with the exception of my legs. I woke up and I looked down and I noticed that my legs were swollen, and so I thought that was odd. But I worked in the school, and so I'm thinking, that's normal. I'm on my feet a lot. I'm walking around. I'm assisting children and adults, and this is part of the job. I also had just gotten back to work a month or two before because I had a daughter in March. And so I took the summer off and then had gone back to work. And so I didn't think it was abnormal. I thought that maybe I just had done a lot the day before and the swelling had started to come. And so when I got to school, I decided, I was going to go through the day and then figure out if hopefully it would go down, and I'd figure it out after that particular day. Maybe I'll put my feet up a little bit once I got into my office, and just all of those things. It was a normal day. I had a lot of activities planned. It was new student orientation. I was excited about taking the new students around the building and giving a tour. And so I was just going about my normal activity, and I decided to stop and ask the school nurse what he thought was going on with my legs, just to get some insight. Like, I thought he would just say something simple, or drink a little bit of water, or do this or do that, and be on my way. Well, he told me to go to the emergency room right away. And I hesitated. I wasn't going to go, but I said, okay, I'll go. And he said, I think someone should take you. And so I was like, well, maybe this is a little more serious than I thought. And so fast forward, I get to the emergency room, and I remember the day in 2006 as if it was yesterday. And the nurse came in after they had done blood work and testing, and she said, "Your kidneys are failing." And I never equated my kidneys failing with the swollen legs at all. I just thought it was just, I was on my feet the day before. And so she told me I'd be admitted. It's just like everything was a whirlwind in a matter of moments. She told me I'd have to stop nursing my daughter. Like everything seemed to just come to a halt that day. I mean, it just literally, our lives were turned upside down. And so I was admitted to the hospital. I had to call my family and let them know. They too were just as confused as I was that this was happening. And I thought I lived a relatively healthy life. And so it really just took us by surprise. I didn't have a family history that I was aware of kidney disease. And so it was really just a shock for all of us. And so I stayed in the hospital for several days. They were trying to figure out what was going on, trying to get the swelling down, trying to stabilize my kidneys. And they finally came to a diagnosis of FSGS kidney disease, or focal segmental glomerular sclerosis. And so I was shocked. I didn't know what it was. I began to Google and just try to figure out, and I thought back over my past, and I started to try. I knew that FSGS represented some type of scarring, and your filters become scarred. And so I started thinking back over my life, like, what did I do in my childhood or in my young adult life to cause this to happen? And so then I just decided to become more educated about FSGS. And so my kidneys were held at bay for about 6 years until it took a turn for the worst in 2011. And so I'd gone back to work at this time, and I was, my kidneys were stable. So I was, working and things like that. And then I was told that I was possibly going to have to start dialysis. And I was in denial. And I tell everyone, and I'm speaking on behalf of my kidney warriors here, and even for care partners, that many times you do experience the grieving process. And so for a long time, I was in denial about starting dialysis. And I didn't want to imagine that for my life or for my family. And so I made the decision to start. Long story short, because I have so many other slides to go, the long story short, I did hemo and peritoneal dialysis until my sister stepped forward to be my kidney donor. And because of her sacrifice, because of her courage, because of her bravery, I sit here today as a 10-year kidney transplant survivor. We were a 6 out of 6 antigen match, and I am forever grateful to her. And I tell her every day that I'm so grateful for her sacrifice and for all that she did to even get to the transplant table. We experienced a lot of hurdles and obstacles to get to the transplant table, but I'm forever grateful that she did not stop at the no's that we received, and she continued on the journey. Next slide, please. So as a result of my journey, as you can imagine, it was a whirlwind. We'd be here all day if I had told every part of it. But one of the things that really struck me when I was diagnosed, and then even when I started dialysis, is that I didn't know a lot about kidney disease. Like, I could tell you about cancer, I could tell you about heart disease and some of the other things that we see discussed often in the media and within our communities, but I didn't know anything about kidney disease. I didn't know a lot about kidney function and how it worked. I knew I had 2 kidneys, but beyond that, I didn't know a lot about it. And so when I started dialysis, I remember walking in the first day for treatment to do in-center hemodialysis. And I remember thinking, why aren't we talking about this? Why aren't we having conversations in our community? It just really struck me when I walked in. Most of the people looked like me. They were African American or Hispanic, and so it really just it hit me like, why aren't we talking about this? If this is going on in our community and there are dialysis centers on almost every corner, why aren't we having conversations? Why aren't we sharing with the generations behind us so that hopefully this wouldn't happen to them? And even in talking to some of my kidney warrior friends who I had connected with in a dialysis center, they're like, my mom was on it, my dad was on it, now I'm here on dialysis. And so I started to think, well, when are we going to stop these cycles? When are we going to position ourselves to be the change that we want to see in our families? especially in communities of color like mine. And so as a result, I used to sit in the dialysis chair and just brainstorm what I could do to be a part of the change. Now, mind you, I was in denial at first. So I had come a long way to even want to share my story and even want to do something differently. But my perspective had changed by this point to, why not me? And what can I do to be the change that I'm looking for in my community and around the world? And so Kindness for Kidneys was formed on December 2nd of 2018. And our goals are to educate, empower, and encourage kidney warriors and their families. And by sharing my story and my sister's story, we're helping to dispel some of those myths. I believe in meeting patients where they are. So yes, we could go and put a flyer in a facility, but it makes a world of a difference when we go and actually sit in the facility throughout the day and talk to the kidney warriors, get a feel for what their needs are, and really make sure that our initiatives are centered around that. And so these are some of the things that we do here in the pictures. During the holiday time, we go and we sing Christmas carols and we pass out care packages because it was important for me, especially during the holidays as a kidney warrior. A lot of times you're already in a reflective space, and it's just important that we remember those who oftentimes feel lonely. And I remember what that felt like to be on dialysis during the holiday time. So that's always my favorite time of the year, my favorite initiative. We also host support groups, and we have an education program that we offer to families just to help them navigate and to connect them to resources in the community once they're diagnosed with kidney disease. Next slide. And so as I begin to, serve the community and just get involved in the kidney community, I wanted to ensure that by sharing my story that I was dispelling myths and helping any family that was impacted by this. As you can imagine, our family, it really, really impacted a lot of us. People had to step in to help with my daughter. My husband, just had to take on a lot more responsibilities as far as working and everything like that for the times that I couldn't work. And so you really feel alone sometimes as a family trying to navigate through it. And so I began to search for answers in where my kidney disease may have originated from. Like I didn't know anyone else with FSGS except for those in the kidney community that I'd started to get to know. And so I started to just want to find out more about it. And I started to hear APOL1. I would go to workshops and conferences and just hear about APOL1, APOL1. And then I would see where FSGS was connected to that. And so I'm like, well, I wonder if that's what I have. I wonder if I have the APOL1 gene. And I started to think back in the beginning of my journey where I felt guilty and ashamed about my diagnosis and wondering what I did to deserve it. And maybe it wasn't me. Maybe it was something that maybe it was genetic. Maybe there was a family history that we didn't know about. And so that's where my search for answers started, just wanting to know what caused this. And I know things that already happened. I know a lot of people say, "What's already done now? You've been on dialysis, you have a transplant. Why find out the origin?" But I started to think about my daughter and generations behind her. And if this was in fact genetic, then I wanted to know so that I could share it with her and she could be mindful and take the steps necessary to be prepared if God forbid anything like that happened. And so I went to a workshop, and again, I began to ask around, and many of the companies that were offering genetic testing, they were only offering it to people who were not on dialysis or transplanted. And so, of course, that counted me out as a transplant warrior. I was like, okay, so how do I find out? Where can I find a test for people who have already had a transplant that just want to have some answers and know? And so I was at a workshop, and one of my kidney warrior friends, Kevin Mott, said, well, I did the 23andMe health assessment. And I said, oh, okay. I didn't know they offered it. And I didn't know that I could find out more about my kidney health by doing this assessment. And so he said, yes. And also your FSA will cover it, cover the cost because it could be a little pricey. And so I said, okay, well, I do have an FSA account thanks to my husband's insurance. And so I decided that I was going to go forward with it. And decided to start with my doctor first, just to ask him if he knew of any my nephrologist to ask him if he knew of any genetic counselors around, or because once I got the results, I definitely wanted to dig a little deeper. And so my doctor said, well, no, I'm not familiar with any genetic tests that you could take or any organizations. And I was almost like, well, when you find out, let me know. And that kind of bothered me as well. And I'm like, well, this is a trusted person. I've been with my nephrologist for years, and he had no idea of where to point me in our area or anywhere for genetic testing to get more answers about my health. And so I resolved to doing the 23andMe DNA test. Next slide. And so I ordered the test. The test came in, and then all of a sudden, fear set in. I got the test, the box set on my dresser, and I would look at it, and I'm like, I don't know if I want to do this now. And there were so many things that went through my mind, like, oh, yes, I know I have FSGS, but what if I find out all this other stuff that I have going on? Do I really want to deal with that? Do I really want to take on any other conditions or things to worry about? And so the test sat on my dresser for quite some time because I went back and forth like, do I really want to do this? And then I started to think, because of the history of our healthcare system and just even some things that I had experienced, I started to think, well, what if they use my DNA for something? Or what if something happens and my DNA is brought into a situation that it shouldn't be? And so I just had all of these what ifs, what ifs, what ifs, what ifs. And so I left it sitting there for several weeks, and I resolved to maybe not doing it, but I had it available if I decided to do it. And then, the more I talked to people about it, my family in particular, and just thought more about it, I prayed about it. I decided that yes, we need to know. We need to know. And so it became a why not me? If I have to be the test dummy or the person in my family that gets this done so that we have more answers, then why not me? And as I said before, it wasn't necessarily about me finding out answers for me, because I knew I had the FSGS and I'd gone through all of the things with that journey, but more so for those people that were coming behind me, my daughter and grandchildren and their children. And if this was something that was in fact genetic, I probably needed to know more about it so that I could tell my siblings, my parents, and so forth. And so I decided to move forward with the testing, and I completed the test. Next slide. And so as a result of the test, I did get the results back, and I do have 2 copies of the G1 variant. And after receiving the results, I wasn't sure how I was going to feel about it, but it was almost a sense of relief. And the report came with several scenarios and situations and follow up and what you should do to follow up. And I, read through that thoroughly, and it did give me a sense of relief. I didn't have the feelings that I once had when I was deciding on whether or not I was going to actually do the test. And so once I got the results back, it was kind of like, wow, so it wasn't my fault. This was something that was inherited, and granted, wasn't my parents' fault either, but now I'm able to tell them what happened to me. And as a result, I got the G1 variant from my mom and the G1 variant from my dad. And with those two combined in me, it increased my risk for kidney disease. And so I was able to also share it with my siblings to let them know and to just put them on guard and be aware. And we're still unpacking it because I just got the results a few months ago. As I said, it sat on my dresser for a few months. And so just got the results back in February. And we're still kind of unpacking where we go from here. But at least we have a starting point. Just want to leave some tips and things as we're talking about access and awareness from a patient perspective. As I shared in my journey, it's a journey to even get to accepting what's going on with you, and also accepting wanting to even know more and to dig deeper. And so these are just some tips and some things that we should think about as we continue to raise awareness of APOL1, and also try to meet the needs of the communities that we are serving. And so the first thing is meeting families where they are. It's important. Many times I can remember, even when I was on dialysis, people would show up in our lobby with a flyer or a pamphlet or things like that. And sometimes that's just not personable for our patients. And so I think it's important, especially if you're going to promote in a community, to get to know the community, to figure out what they're motivated by. And so you can do that through trusted community members, whether they're church leaders or community centers or barbershops or salons. Just kind of getting to know the community that you're targeting is very important in how you approach them. Also, of course, as I said, my nephrologist had no idea of where to point me in the direction for genetic testing. And he's someone that I trust. He's someone that I feel a connection to, that I've established a relationship with over the years, but he had no idea of where to point me in the direction. And I can see many patients just stopping there and saying, okay, well, my doctor doesn't know, so I'm not going to be involved. And so it's so important that doctors are educated on what's available, even if there's a resource list that they're given, so that if a patient asks for more answers, or even if they just want to promote it to them, it's important that they're aware. That includes your PCP providers, all of them. They need to be aware of what's out there as it relates to genetic testing, because there are patients like me who want to know more, and our first line of defense many times is to come to our providers, those that are caring for us in our healthcare. Um, Going to community events. Communities have events all the time. And I know with Kindness for Kidneys, we do a lot of health fairs, and we go and set up tables and we talk to families that come through. And so that's a good way to just even start a conversation about it. Many times you may not have people to sign up at a community event, but at least to start the conversation, to have advocates there to share their experiences when people are coming to the tables is a good start as well. And then follow up. One thing that I find with community events or community awareness initiatives is, once we have the patients, once they decide to sign up for the clinical trial or to come on board and be a part of something, the follow up is not always there. So I may go as a patient advocate and share my journey and share things or give feedback on materials, but then from there I hear nothing. And so I think that's important as we're meeting with families and we're asking them to possibly participate in trials and get genetic testing, that there's some follow-up there. And even beyond that, pointing them to resources in their community that they can continue in their journey, in their health journey. And so I just wanted to leave you with those tips. Again, I want to thank the Kidney Health Initiative for this invitation and for the opportunity to share my journey as a kidney warrior. And I look forward to many more opportunities to be a part of wonderful initiatives like that, like this. Thank you.
Thank you so much, Sharon. I want to echo some comments that have been posted by Christina and Michael Gilchrist, who says, Sharon, you are amazing. Thank you for all of this, in all caps. Jasmine, who says, I love kidneys, Kindness for Kidneys, love the work Sharon does. And I think we all echo that. Thank you so much for sharing your story. Really just moving, wonderful presentation. Nice work. Lots of comments. Next, before we move on to the next presentation, we are going to have a poll activity sort of to gauge and just see where the audience members are. And so we'll put up a question and you guys can choose a response here. Great. So question is, what is your primary interest in APOL1 genetic testing? Understanding the genetic risk associated with APOL1, learning about the latest advancements in APOL1 research, exploring genetic counseling options, networking with and experts in the field, or something else. We'd like to hear. Take a moment to answer, and then we will move on to review the results with everyone. Wonderful, and I do want to share the results, sort of an even spread, really a lot of folks, about 19% of you want to understand the genetic risk associated with APOL1. I hope we have addressed some of this. Learning about the latest advancements in APOL1 research. This is addressed a little bit, but really more to come on this. Exploring the genetic counseling options for 16% of our respondents, and then networking with professionals and experts in the field. Thank you so much for responding to this poll activity. Up next, we have a special presentation that was prepared by genetic counselor, Ms. Mary Beth Roberts. She is a genetic counselor specializing in kidney genetics at Cleveland Clinic. Ms. Roberts co-founded the Renal Genetics Special Interest Group at the National Society of Genetic Counselors. She's a biocurator for the ClinGen Alport syndrome variant curation panel, and is a member of the Alport Syndrome Foundation Scientific Advisory Research Network. Clearly has a lot of experience in genetics and kidney disease. We're very excited to share her message with you today.
Good afternoon, everyone. My name is Mary Beth Roberts. I'm a genetic counselor at Cleveland Clinic, and I am pleased to talk with you today about genetic testing for hereditary kidney disease. I have no disclosures. So as we know, chronic kidney disease affects about 14% of the general population. It is relevant to this talk that people with recent African ancestry are at higher risk. Inherited kidney disease accounts for about 10% of adult end-stage kidney disease and about 30 to 70% of childhood kidney disease. We can compare that to a monogenic cause of breast cancer in 5 to 10% of cases. About 20 to 30% of patients report a family history of CKD in a first or second degree relative. And so it makes sense that family history of CKD significantly increases the chance of finding a genetic etiology. About 20% of patients, 1 in 5, who develop CKD before age 25 have a monogenic cause, and about 1% of the general population will have a genetic kidney disease. Nephrology is not yet a common source of referrals for genetic counseling, but there is a growing body of literature supporting genetic workup as standard of care when indicated. I am biased, but I like this quote. A genetic counselor is like air conditioning. When you do not have it, you do not realize that you're missing it. But when you have it, you cannot live without it. There was a significant expansion of genetic testing options for CKD since 2018. Many commercial labs now offer a variety of targeted panels, as well as a broad kind of 300 or 400 gene CKD panel. The National Society of Genetic Counselors Renal Interest Group was founded in December of 2020. We now have about 84 members as of, I think, when I checked yesterday. And that's a mix of genetic counselors in laboratory, clinical, and research roles. Our website is listed there. There's also a QR code that will take you to our Renal Sig Pocket Guide resource, which was something we developed for referring providers who are wondering which of their patients may be indicated to be referred for genetic testing. National organizations supporting kidney patients and kidney disease research are starting to prioritize strategies to incorporate genetic testing in counseling. And I've highlighted that genetic testing is increasingly having a major impact on precision care for patients with kidney disease, with things like extrarenal screening, changes in medication strategy, informed living donor selection, gene therapy, and others. And I'll also point out that genetic testing really cannot only be offered in academic or research settings. This is something that really needs to be widely adopted by community nephrologists. So renal genetic counseling has some unique kind of settings when we're talking to kidney patients. So genotyping frequently provides prognostic information about progression of disease or response to medication. The focus of the results is frequently on how they may change medical management or provide more information about prognosis, which is similar to genetic testing in oncology. Results can influence whether the native kidneys are removed, as an example, after transplant. Usually they're not, but in some cases that would be indicated. And then decisions like whether to continue steroids or immunosuppression in a pre-transplant setting, extrarenal surveillance, like I mentioned, and then follow-up after transplant. We can also sometimes give information regarding the recurrence risk of kidney disease after transplant. So there's virtually no recurrence of the primary disease with a genetic FSGS, but a high chance with non-genetic cases. And then results can be helpful for considerations like continuing, eculizumab for somebody with atypical HUS after transplant. This is a very expensive drug. We get a lot of referrals for living donor counseling. So this would be pre-symptomatic genetic testing as part of a donor health screen. It is strongly recommended to know the familial variant causing a relative's kidney failure before sending the donor for genetic testing. There's a unique psychosocial element for renal genetic counseling. So family screening has a greater impact on patient and their relatives if living donation is under consideration. And if more than one family member is affected, counseling may include difficult decision-making about who gets the priority for a healthy kidney in an affected family. I'm going to focus on APOL1 for the rest of this talk. I know that we've talked about this in other sessions, but I'll just do a quick review here. So people with recent sub-Saharan Western African ancestry, which is most African American or Black Americans and some Hispanic Americans, have 4 times the chronic kidney disease as people with European ancestry. For the sake of this talk, I'm going to use an acronym ARAA, which stands for Americans with Recent African Ancestry. So up to 70% of Americans with recent African ancestry with non-diabetic end-stage kidney disease, which is about 40%, of folks, have high-risk variants in APOL1. About 75% of Americans with African ancestry who have FSGS have a high-risk genotype. And about 50% of Americans with African ancestry who have hypertension attributed end-stage kidney disease have the high-risk genotype. This is a lot of people. It's almost 40% of Americans with recent African ancestry are carriers for one high-risk variant. This is a carrier frequency of 2 out of 5. But carriers are not at increased risk of APOL1-mediated CKD. About 13% of Americans with African ancestry carry 2 high-risk variants, and they will have an increased risk of APOL1-mediated CKD over their lifetime with about a 20% risk. Increased risk genotypes are any combination of high-risk G1, G2 alleles. That's G1, 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 G2, and G2, G2. And the types of kidney diseases associated with APOL1 risk alleles include FSGS, nephrotic syndrome, severe lupus nephritis, sickle cell nephropathy, HIV-associated nephropathy, and CKD attributed to hypertension. It was my pleasure to be a contributing author for a recent publication from the NKF and AJKD. This was the Genetic Testing Working Group. And we have a lot of great recommendations about genetic testing and kidney disease in general, but I pulled out the relevant points about APOL1 to share with you. So these are statements that reached general consensus within the group. APOL1 should be included in gene panel assessments of chronic kidney disease and offered to patients having clinical manifestations or biopsy findings suspected to be related to APOL1, regardless of race or ethnicity. APOL1 genetic testing should not be limited or recommended by race or ethnicity of the patient. So for limited use, you risk missing people with unknown or unreported African ancestry. For recommended use, when it's a single gene test, you risk missing other monogenic disorders that overlap with APOL1-mediated CKD. So a cost-effective approach is the use of multi-gene panels that include APOL1 alongside other FSGS or nephrotic syndrome genes. The medical community should be educated on the indication of genetic testing for APOL1, its implications for kidney disease and its progression, family counseling, and other legal or ethnic considerations. Living donors who are related to patients with high-risk APOL1 variants should be considered for genetic testing. Consensus wasn't reached on this next statement. We came close, but it didn't quite meet the threshold for agreement. But there is currently not enough evidence to make firm recommendations for or against APOL1 testing to predict which donors would be at increased risk of CKD following kidney donation. Results from ongoing APOL1 clinical trials and transplantation settings may clarify indications for APOL1 testing of at-risk kidney donors. Therefore, there are no specific recommendations regarding testing for APOL1 risk alleles in individuals without diagnosed clinical disease. And I highlight this because I've got some information in my next slide that raises additional questions about genotype screening for healthy people. The panel felt that APOL1 testing should be included in gene panels for CKD evaluation and offered to patients with clinical findings suggestive of APOL1 associated nephropathy, regardless of race and ethnicity. And nephrologists should inform patients and the general kidney community of the limitations of the Genetic Information Non-Discrimination Act, or GINA, which protects individuals against genetic discrimination in the workplace and their health insurance, but does not extend to life, long-term care, and disability insurance. So I've got the website there, ginahelp.org, to link to more information, and the QR code up top. So to make this complicated risk evaluation even more complicated, a paper was published at the end of last year. The authors have found a strong protective effect of a variant called N264K against a G2-associated FSGS and kidney disease. So what does this mean? Well, this variant substantially reduces the penetrance of the G1, G2, and G2 high-risk genotypes when co-inherited. The N264K variant negates the toxic effect of the G2 allele, and it is not seen in the G1 allele, so they are mutually exclusive. Some quotes from the paper that I pulled out to share. The N264K variant seemed to confer complete protection against FSGS, as it was never observed in cases in the presence of the G2 genotype. APOL1 high-risk individuals are at least 8.3 times less likely to develop FSGS if they carry one copy of this protective variant. And the authors observed a very large effect of this variant on mitigating the consequences of the G2 risk allele, but saw no evidence of this variant of the more common G1 risk allele. And they say, as a consequence, because the N264K variant and G1 alleles are mutually exclusive, this finding raises the possibility of additional genetic modifiers specific to G1. So as you can see, the APOL1 risk discussion is really a moving target. There are no current commercially available tests to genotype for the N264K protective variant, which is subject to change. Pre-symptomatic screening involving a G2 high-risk allele becomes even more difficult to counsel regarding lifetime risk of CKD. And it's my opinion that individuals with CKD and a high-risk APOL1 genotype involving G2 should be cautioned that their disease may or may not be attributed to APOL1 in the absence of confirming the protective genotype. I'll leave you with some more quotes from this paper. Individuals affected by CKD or ESKD with APOL1 G1, G2, or G2-2 high-risk genotypes, but with the protective variant, are unlikely to have APOL1 associated FSGS, and therefore an additional cause should be investigated. Second, importantly, in kidney transplant settings, these results can significantly affect donor selection and both donor kidney and recipient graft outcome. In fact, APOL1 G2 high-risk donors who are positive for the protective variant will likely have kidney outcomes similar to any of the low-risk donors, therefore expanding donor pool, and kidney transplant recipients of an APOL1 high-risk kidney with the protective variant will likely have low risk for developing de novo FSGS on the graft or graft failure from APOL1 associated kidney disease. Third, incorporation of this knowledge will allow more accurate study design for new intervention trials. So thank you for your attention this afternoon. It was my pleasure to speak with you today, and I hope you enjoy the rest of your sessions.
We're so grateful for Ms. Roberts' time and relevant contribution to the conversation we're having today about genetic counseling, genetic testing, and genetic counseling. Please do share any thoughts on her presentations in the chat, and we'll be sure to pass them on along to Ms. Roberts. Thank you again, Mary Beth. And with that, we'll move on to our next poll activity for the audience. We will put up a question about when do you believe is the most appropriate time for individuals to undergo APOL1 genetic testing? We're curious to hear. The possible answers include during routine health checkups, when there's a family history of kidney disease, after experiencing symptoms of kidney disease, when considering starting a family, or if you're not sure and need more information. I'd like to hear that as well. I'll give you a second to answer this. Okay, so we have some results. 24% of you said during routine health checkups. 56% preferred when there is a family history of kidney disease. 12% said after experiencing symptoms of kidney disease, and 4% each for when considering starting a family, and 4% were not sure, needed more information. Thank you so much. That's very helpful to understand. And I think it will make for some interesting discussion points as we move on to the discussion portion or the Q&A portion of our session here. First, what I'll do is I will highlight some questions that have come up in the chat, and then I think Sharon and I have some questions and thoughts that we'd like to share as well. But thank you again for everyone who's participated. Please do put your thoughts in the chat. They're being monitored. So Jorge asked, hello, professors, is it possible to find these variants in Latin American countries that have been influenced by migration of people of African origin since the time of colonization and slavery? A very important, very interesting question, Jorge. And I think the short answer is yes, this is certainly possible. There have been studies showing that dialysis populations, particularly in Brazil, have an enriched portion of patients with high risk alleles. I think there is someone else in case they want to answer. Please do feel free to answer, Setsia, if you want to step in. And then the next question that's brought to us is lifestyle modifications. What are the lifestyle modifications that can mitigate APOL1 associated risk of kidney disease? How much difference does starting early make? This is an important question, and I don't know that we necessarily have an answer, Sharon. I'm curious to hear your response once I sort of explain my thoughts. I think there's a lot more that we have to understand about APOL1 disease, certainly trials and different therapies, therapies that we use routinely for hypertension if it's associated with the disease, starting early versus tight control of blood pressure, tight control of protein. All those things yet have to be answered, and I think there are ongoing studies and hopefully more studies in the future that will address some of these. Sharon, I'm curious to hear if you have any thoughts or perspective on this.
I would just say just leading a healthy life in general would help with it. I don't know, because it is genetic and everything, if there's anything that you can do about that. But as far as prolonging maybe the onset of the symptoms and getting to the end stages, I think just doing what we would recommend for overall health, which would be drinking water and low sodium and low sugar diet and exercising and the main things that we think about when we think of of overall health. And then also going to see your provider and making sure you're staying on top of those things, I think would be helpful in just being aware. And then if there's a family history, of course, being on top of it even more, going to see a nephrologist would be my response.
Yeah, I agree. Lifestyle modification, understanding your risk before you even initiate lifestyle modification I think is so important, which is where the genetic testing may come into play. Anything else? Sharon, you brought up a lot of really, really important points during your talk, and I was sort of taking notes. Um, some of the things I wrote down really stood out to me is thinking about this journey, meeting your family, meeting families and community members where they are. Um, and really that, from as a clinician, I meet families in the clinic, patients in the clinic, and you're absolutely correct. It is a journey. You have to develop the relationship. As you said, you have to understand what motivates our families and patients before you can sort of delve into all of this. So I really want to thank you for highlighting that. And I think for each of us, it's a different context of where we meet patients and families and understanding what motivates them. I'm curious, and from your perspective, how do you think a healthcare provider, I know you've already mentioned, educating providers, nephrologists is important. What else do you think providers can do to better support patients who are undergoing testing?
So first, being aware of what's available. It's important to stay abreast of research and clinical trials that are out there so that patients have that knowledge and the provider can share it with the patients that they see. Again, I trust my nephrologist. I've been with him for several years. And so if he came to me and recommended something or said to me, hey, have you heard of this study or have you heard of this trial? I'd probably be more apt to listen to him rather than if I saw it come up on my screen or an email or something like that. And so I think as a provider, it's important to just be aware and knowledgeable of what's out there, what innovations are out there, and how patients can take advantage of some of these things ahead of time. Also, just being available. Sometimes I know with your schedules, it's tight, so it's like I got to get them in and get them out. But just patients understanding that my provider is available to me, that they really care about me, that they listen. And I can speak for my nephrologist that he really does care. He knows my family. When I come, he's asking about my family. It's not just okay, here are your labs. Let's, you look like you're doing fine. See you next time. See you in 3 months. It's more than that. And he shares himself as well. So he talks about his family and showed me pictures of his son's wedding, and just it's a relationship. And many times we're so focused on what we're there for that we miss out on the relationship piece. And as that relationship is built, as a patient, I'm more apt to listen. I'm more apt to be open to you and my needs and what's going on in my life. And I think that makes for a better experience for both of us.
Yeah, and I was really touched by your mention of, when you were thinking about moving forward with the testing, you really thought about it in the context of your family. So as a provider, if I understood that, you have young kids and want to know what will happen and how your genetic results may impact the future generations, I think sort of approaching it from that perspective may have also, again, having that relationship would provide that context as a provider to
Absolutely.
it from that way. We have some other questions in the chat here. Is there anything that has been discovered to ramp up this kidney disease? I interpret this as sort of anything discovered to help treat this kidney disease, and you can correct me if I'm wrong. So while I mentioned that there are no approved therapies, there are several ongoing trials and treatments at various places across the world, really, that patients can register in their registry studies. Apollo is a study that was previously mentioned, and there are ongoing studies by Vertex. There's an ongoing study at Duke Health. So there are many studies, but nothing yet approved. And as one of the goals of the roadmap is that we know where we stand now. In the future, hopefully there'll be more genetic precision specific therapies for patients who've undergone genetic testing. And so we can better equip patients to make those decisions about treatments. one other thought that I had, Sharon, as you were talking, one of the things you really highlighted, which made me think, was about follow-up. You said, you go to many things, or community members may go to events, and they get information, or they enroll in studies, they participate, give time so generously and energy, um, but then there's no follow-up. And I think that's really, really important. What sort of follow-up do you think would be important? Things that came to my mind are, there's individual follow-ups that we often do for studies, where our coordinators will call patients, or the patients have to come to us to follow up for therapy studies. There are emails, there are newsletters that some organizations do. What sort of things do you feel are more very effective to engage uh, families, community members who've already given so much time?
Some of the ways that you've described, so having families come in. Um, I was on a call not too long ago, and I said, even I would even love to receive a postcard saying, "Hey, look at the results of this study, and how your input has impacted our research." And just to have, because a lot of times we give our input, but we don't always see the end result. And sometimes to me, it's helpful to see the end result, to know
Mhm.
that yes, my voice does matter, and it's going to make me want to do more, and so it makes me feel that I'm not just a number, that I'm not just oh, they just brought me in just to get their stuff done, and then I never hear from them. And so I think just simple ways, even if it's an email follow-up. Hey, you participated in this study last year, just wanted to kind of give you some of where give you an update on where we are, and where we're going with this. And if you have any other feedback that you think would be helpful along the way, feel free to shoot us an email or a text, or just some way of connecting and staying, so that we're abreast of what's happening, and can then take that back to our communities and share it with other people. And so just having some sort of follow up, like you said, bringing families in. If I'm participating in a clinical trial and maybe it's done, having some sense of, okay, where did it end? Where are they now with it? Did they discontinue it? Is it
Mhm.
gone? So just to know those things is helpful as a patient advocate, and just helpful for families in general to know that no, your participation was not in vain, that you really were an important part of this. And as a result of your participation, here's where we are with it. And this is where we're planning to go.
Wonderful. I totally agree. I think it really builds a community approach to these studies. Here at UNC, we have a separate registry that has been ongoing for many years. And one of our goals is to do an annual newsletter. And I enjoy reading it. Patients contribute to the newsletter, our providers, our research coordinators. It really just, even reading the newsletter, it's brief, but it feels like a community that we're part of for in our cases for glomerular diseases. So yeah, I totally agree with that sort of time investment on both sides. Anne Froment, also from UNC, has this comment to address what we were just talking about. She says results from clinical trials can take a couple of years before they're available. Maybe pharmaceutical companies who are sponsoring these could send yearly updates about the process. Otherwise, it does look like a lack of follow-up. Thank you, Anne. That's absolutely a
That's a
fantastic
great,
idea.
yes.
Another question from Brooke Berry is, what are your thoughts on risk of discrimination surrounding knowing APOL1 results, despite GINA, which I mentioned? And then how can providers, counselors, researchers address this? Sharon, as someone who's undergone the genetic testing, I'm really curious to hear about your perspective on the first part of that question, and even the second part of how you can be supported, or patients can be supported.
Right. And that's a great question, Brooke, because I too feel that that was a part of the fear that I was experiencing. Like, if I have concrete evidence to show this is what the origin of my kidney disease is that going to follow me somewhere else? Will someone mysteriously get the results and I be penalized for it? And so I don't feel like I have a straightforward answer with it. Um, for me, I think it just really depends on your motives for wanting to get answers through the genetic test. And in my case, my motive was I wanted to be able to support my family and give answers to my family in doing so. And so I really feel like that's going to be an ongoing thing as far as preventing discrimination, because even now, there are things that, because I've gone through kidney disease and all of that, that I can't take advantage of as it relates to insurances and things like that. And so I still feel like there's some opportunity in that area when it relates to people finding out diagnoses and they not be penalized for certain things, like life insurance and things like that. So I would say, there's still a lot more that we need to uncover in that way. And I don't know that we can ensure that discrimination won't happen.
You're absolutely right. And I think, and when you refer to things that are yet to be uncovered, that has to be part of our understanding as we move forward to address policymakers to fill in those gaps, because we need to know from advocates, patients, families, what those gaps are, where they're facing the discrimination, and how we can support them. I think policy is one very strong way of protecting people against discrimination. And the other
Yes.
thing I think that's important to consider is, how do we share the results? You mentioned fear of, are they just going to have my DNA? Is this information just going to be out there? We have to be very, very mindful of where this is shared, how it's shared. If it's being shared in the EMR, who has access to the results of that to the reports in the EMR? If it's being shared with patients, how are we doing it? Are we sending a specific mailing to each patient? Are we handing them the genetic results in an envelope in clinic? And then the next part of it is, how are we explaining the results to the patients? Is there a genetic counselor available? Is a provider who carried out or ordered the testing feel comfortable in explaining the results, the implications?
Yes.
Those are, I think, all sorts of part of that same question. Thank
Yes.
you, Brooke, for
Oh, I'm sorry.
asking that.
I'm sorry, Dr. Chit. I was chiming in as you
Please.
were talking. I apologize. Yeah, and I think too, even beyond that, I think what happens is we get the results and then it's kind of like, now what? And so, as a community, we need to think about, okay, we've given this family the results. We know that, yes, they have this going on. Now what? Like, what resources are out there beyond now? And so I'm really looking forward to the Kidney Health Initiative, thinking through some of those things. Okay, once someone has gone through the testing and they've gotten their results, and yes, maybe their family is impacted, what do we do now? How do we support them afterwards? It's kind of like when you go to a funeral service and people are like, the family's going to need support beyond today. Yes, you all have been very supportive up until this point, but going forward, and so I think as a community, we have to begin to think about that. How are we directing them to resources outside of this testing? And once they do get the results, how we support them moving forward. And that takes a community approach. It's not one person can't do it alone. And so we think that's something that we'll really have to continue to work on and think through, because many families go and they feel left alone after they've gone through testing and clinical trials and things like that. It's like, I know, but now what? What are we doing now? And then how we can then impact their circle of influence, so it doesn't just stop with their family. And so that's always important.
I completely agree. I think starting that discussion is a starting point, and then having multiple sort of places where people can get information. Patient advocacy groups, I think, are huge for this, because patients feel very connected to each other. Understanding others' experience firsthand also helps. I can sit there and sort of talk about G1, G2 risk variants, but it may not really connect or hit home until they understand how it's impacted other community members.
Yes.
Absolutely. What are some thoughts on how your group, in particular, other groups you've seen, engage with the community to raise awareness?
Um, Health fairs are a big one. There are a lot of back to school celebrations that are getting ready to take place. And so being a part of things like that, where we know the community is already going to come, is very important. We're actually we're going to have an event this weekend at a church, and they asked us to come and set up. And so that's always a good way to just raise awareness. And we always hear people come to the table and say, oh yeah, I have kidney disease. Or the last event we did, a lady came up and said, oh my goodness, I've been praying for a group to connect to. And so we have to get ourselves out there in the community and go to places where we know the community is going to go. So the back to school drives, the community centers, places that we know they're going to frequent, like the barbershops and the salons. I'm looking forward to Kindness for Kidneys getting into the barbershops and the salons, because that's another trusted environment, and we know that people are going to go there frequently. And so I'm looking forward to kind of tapping into some of those spaces. We used to do that when I was in education. We had a barbershop books program where we would put books in the barbershop and train the barbers on how to work with their patients. And yes, definitely places of worship. Gifte mentioned is a huge place, because that is another trusted source in most instances where people trust their pastor. I know a lot of pastors too are starting to get involved in hosting health fairs and kidney awareness events. And so that's been really a huge, I know one of the pastors, and I can't think of his name, in Philadelphia, he has a men's event, and they offer lab work there. They offer, information on kidney disease. And so a lot of men come out and take advantage, and they have influencers come, and people that have been impacted, like Freeway Willie, come to the event. And so those tend to be highly attended events, and then also very participatory among the people that come, because of this person spearheading this event, and it's someone that they trust and who's been vetted and all of that. And so those are just some of the areas and some of the things that I think we can continue to tap into, because it is going to take a village. I always say it's going to take a village to change the narrative surrounding kidney disease and kidney health. And so we have to tap into all of the resources that are available.
I think as a provider, that's super helpful for me to understand that I have this additional support, because as you mentioned, we only have so many minutes in a clinic visit. My strategy in terms of educating families and patients has been sort of layered. I, especially when first meeting patients, understanding what's important to them, really getting kind of taking care of the urgent needs of their disease is important. And then as I get to know them better, we have some additional discussions about genetic testing. And then even if it's not relevant to that particular patient, I, talk about it in the broader context, because oftentimes I'll say, so who else in your in your family has kidney disease? And they'll sort of start opening up about grandparents, aunties, uncles. I say, well, one of the things that has come to light in the last 15 years is this genetic risk factor. I don't know if you have ever talked about it with your family, if you considered it. Here's some information, here's some studies that you can get free testing if you're interested. Just sort of starting that engagement and discussion in a way that's not overwhelming. Already, I know I'm giving so much information, but I think even if they've sort of heard about this and then they go in the community, go to these health fairs you're talking about, find these patient advocacy groups, find information maybe even on social media, then it's sort of, at multiple levels, you're saying, oh yeah, this is something that we need to learn more about, and hopefully getting information from a variety of resources and education. So I
Absolutely.
really enjoy hearing your perspective, because I think you are so unique in that you're an educator before all of this. And so you also have that unique perspective.
Thank you. Thank you. And just to piggyback on what you were saying about that, I think in addition to the relationship piece behind it, I think you've just brought up some good points. And it also took me back to the numerous times that I've heard about APOL1, to finally hear in what 2023, the end of 2023, deciding to do it. And so I think that speaks to the importance of, like you said, there being multiple touch points, because most aren't going to get it on the first view. Most aren't going to say, oh yeah, let me go do this on the first few. And when you were talking, it just took me back to the number of conferences that I've gone to, that I've heard about APOL1 for years, but I never felt compelled to do anything about it or even find out. And so I think that, that's something we can leave our audience with today, is that it may not happen on the first the first encounter, But if we all continue to raise awareness, and there are multiple touch points for families, that somewhere down the line they may decide that, hey, let's take a look into this for us and see if we are impacted by this variant, and so forth. And so just thank you for bringing that up, because it took me back, like, wow, yeah, it took a lot of, information and just touch points before I finally said, okay, let me try this. And then also finding out that I could do it through 23andMe,
Yeah,
because I
having
never knew.
access.
Yes. So that access is very important, and families understanding that, hey, you can do this here, or here's a free site that's offering genetic testing. And so I hope we get there soon as well.
Thank you so much. I really think this is a great point to pause, and let me take a look at the other questions. How about getting on local radio in the community? Is Gift Day's idea. That's fantastic. Thank you all. I really do appreciate all the participants, the engagement from the audience. I think I'll present to you the last few slides, and before we all go our separate ways. But I do want to thank you for attending and participating. I especially want to thank the KHI community for supporting this important roadmap, and of course, our presenters today. Next slide. This summarizes our roadmap that I've already talked a little bit about. The webinars that happened last month was increasing awareness and education. It's available online, and I'll show you the links shortly. Today was empowering the community about access and awareness to genetic testing. And then in September, the last part of the roadmap, from awareness to action, really navigating the clinical trial enrollment, what's available, how to navigate that is coming up. Next slide. Oh, okay. And I just wanted to put up these list of resources related to the roadmap, and you can scan this QR code to really be directed to the roadmap. And then we'll share a link in the chat as well. And then if you'd like to view the previous webinar talking about awareness and education and the recommendations of the roadmap for that, you can follow this, this last QR code. And the next slide, please. And lastly, we'd love to hear from you. Take a moment, complete the short survey after this webinar. It'll pop up in a separate window, and we care about your voice. We want to understand what your priorities and thoughts are. And again, I want to thank everyone for putting in their comments in the chat. Thank you, Sharon. Thank you, Mary Beth. Thank you all. And with that, we'll end this webinar today.